Hi guys, welcome to my YouTube channel Study with Dr. Brainiac. Today we will discuss chapter Pharmacotherapeutics in Obstetrics. In we will this video is divided into two parts. Part 1 includes Oxytocin, Antihypertensive, Diuretics, Tocolytics, and Anticonvulsant and Anticoagulant. Part 2 includes maternal drugs intake, that is teratogenic drug, anesthetic drug. So let's begin. Let's discuss part 1. Begin with our part 1. So come to our topic. Oxytocins in obstetrics. Definition: Oxytocins are the important drugs of varying chemical nature that have the power to excite contraction of uterine muscles. Among large number of drugs belonging to this group, the following are the important ones and extensively used in clinical practice: Oxytocin, ergot derivatives, prostaglandins. Oxytocins, important for university exams. Pharmacology: Oxytocin is a nonpeptide. In 1950, D. Vigneault and co-worker did Nobel Prize winning work on the structure of oxytocin, synthesized in the supraoptic paraventricular nuclei of the hypothalamus. By nerve axon, it is transported from the hypothalamus to posterior pituitary, where it is stored and eventually released. Oxytocin has half-life of 3 minutes and a duration of action approximately 20 minutes. It is rapidly metabolized and degraded by oxytocinase. Enzyme working for degradation of oxytocin is oxytocinase. Mode of action: myometrial oxytocin receptor concentration increases maximum during labor. Oxytocin acts through receptor and voltage mediated calcium channel to initiate myometric contraction. Action through receptor and voltage mediated calcium channel to initiate myometric contraction. It stimulates amniotic and residual prostaglandin production. Stimulate amniotic and prostaglandin production. Bound intercellular calcium is eventually mobilized from sarcoplasmic reticulum to activate the contractile protein. The uterine contractions are physiological, that is, causing fundal contraction and with relaxation of cervix. Preparation used: the synthetic oxytocin, syntocin, or also known as pitocin, is widely used. It has only got oxytocin effect without any vasopressor action. The syntocin is available in ampoules containing 5 international units per ml and pitocin 5 international units per ml. Second, symptomatin, a combination of symptomatin is a combination of syntocinon 5 unit, and ergometrine 0.5 milligram. Ergometrine taken in milligram and syntocinon taken in units. Okay, desaminoxytocin. It is not inactivated by oxytocinase and is 50 to 100 times more effective than oxytocin. It is used as a buccal tablet containing doses 50 international unit. Oxytocin nasal solution containing 40 units per ml. Effectiveness: in the first trimester, the uterus is almost refractory to oxytocin. First trimester, almost refractory to oxytocin. In the second trimester, related to refractoriness, and such as oxytocin can only supplement other abortifacient agent in the induction of labor. In later months of pregnancy, during labor in particular, it is highly sensitive to oxytocin even in small doses. Oxytocin loses its effectiveness unless preserved at the correct temperature between 2 degrees Celsius to 8 degrees Celsius. Indication: oxytocin may be conveniently used in pregnancy, labor, or puerperium. The indications are grouped as follows: therapeutic and diagnostic. Therapeutic for pregnancy, labor, and puerperium. Okay, for pregnancy, early accelerate abortion, inevitable or missed, and to expedite expulsion of hereditary mole, to stop bleeding following evacuation of the uterus, used as an adjunct to induction of abortion along with abortifacient agent PGE1 or PGE2. Late, to induce labor, to ripen the cervix before induction, augmentation of labor, uterine anesthesia, inactive management of third stage of labor following expulsion of placenta as an alternative to ergometrine. For labor, these are from to ripen the cervix of induction, augmentation of labor. These uses are important: ripen the augmentation of labor, and uterine anesthesia, and active management of third stage of labor following expulsion of placenta as alternative to ergometrine. Okay. Puerperium, to minimize blood loss and to control postpartum hemorrhage. Look at the table 34.1 contraindication of oxytocin. Pregnancy, labor, and anytime. Current multipara, contracted pelvis, history of cesarean or hysterectomy multipara. Current multipara, all the contraindication in pregnancy. Obstructed labor, incoordinate uterine contraction, fetal hypogamy, cardiac shock. Look at the diagnostic purpose. Diagnostic: use contraction stress test. Contraction stress test, oxytocin sensitivity test. Dangers of oxytocin. The dangers are particularly noticed when the drug is administered late in pregnancy or during labor. Maternal or fetal. Maternal uterine hyperstimulation overactivity is a frequently observed side effect. There may be excessive duration of uterine contraction, hypertonia, or increased frequency, more than 6 in 10-minute time of contraction, polysystole. It is often associated with abnormal fetal heart rate pattern. Uterine rupture may be seen with violent uterine contraction common. High-risk cases such as grand multipara, malpresentation, contracted pelvis, prior uterine scar, excessive oxytocin use. Water intoxication is due to antidiuretic function when used in high dose, 30 to 40 milli international unit per minute. Water intoxication is manifested by hyponatremia, confusion, coma, convulsion, congestive cardiac failure, and death. It is prevented by a strict fluid intake and output record, use of salt solution, and by avoiding high dose of oxytocin for a long time. Hypotension. Bolus IV injection of oxytocin cause hypotension, especially when the patient is hypovolemic or with a heart disease. Occasionally, oxytocin may produce anginal pain. So it is oxytocin is contraindicated in heart patient. Okay. Antidiuresis. Antidiuretic effect is observed when oxytocin infusion rate is high, 40 to 50 milli-international unit per minute, and continued for a long time. Fetal distress, fetal hypoxia, or even fetal death may occur due to uterine hyperstimulation. Uterine hypotonia or polycystic cause reduced placental blood flow. Route of administration. Controlled intravenous infusion is widely used method. Bolus IV or IM 5 to 10 unit after birth of the baby as an alternative to ergometrine. Intramuscular, the preparation used symptomatrine. Buccal tablet nasal spray limited use on trial basis. Method of administration of oxytocin. Controlled intravenous infusion intramuscular. Controlled IV infusion. Oxytocin infusion should be ideally by infusion pump. Fluid load should be minimum. It is started at low dose rate 1 to 2 milli-international unit and increased gradually for induction of labor and for augmentation of labor. For induction of labor principle, because of safety, the oxytocin should be started with a low dose because oxytocin may cause an anaphylactic reaction. So it is started with a low dose. So the oxytocin should be started with a low dose and is escalated at an interval of 20 to 30 minutes where there is no response. When the optimal response is achieved, uterine contractions sustained for about 45 seconds and numbering 3 contractions in 10 minutes. It is physiological contraction. The administration of the particular concentration in milli-international unit per minute is to be continued. This is called oxytocin titration technique. The objective of oxytocin administration is not only to initiate effective uterine contraction but also to maintain normal pattern of uterine activity till delivery and at least 30 to 60 minutes beyond that. Calculation of infused dose. Nowadays, the infusion is expressed in terms of milliunit per minute. This can be given an accurate idea about the exact amount administered per minute irrespective of the concentration of the solution. Regulation of the drip. The drip is regulated by manually counting the drop per minute. Commonly practiced. Oxytocin infusion pump which automatically controls the amount of fluid to be infused. Convenient regime. Because of wide variation in response, it is a sound practice to start with a low dose 1 to 2 milli-international units per minute and to escalate by 1 to 2 milli-international units per minute at every 20-minute interval up to 8 milli-international units per minute. The patient should preferably lie on one side or in semi-polar position to minimize vena cava compression. High dose oxytocin begin with 4 milli-international units per minute and increase 4 milli-international units per minute at every 20 to 30 minute interval. It is mainly used for augmentation of labor and in active management of labor. Risk of uterine hyperstimulation and fetal heart irregularity are more with high dose of regimen. With high dose of regimen, risk of uterine hyperstimulation and fetal heart irregularities are more. In majority of cases, a dose of less than 16 milli-international units per minute, 2 units in 500 ml ringer solution with drop rate of 60 per minute is enough to achieve the objective. Condition where fluid overload is to be avoided. Infusion with high concentration and reduced drop rate is preferred. Calculation of dose delivered in milliunit and its correlation with drop rate per minute. Okay, these are the tables about the use of showing use of oxytocin and how to give that oxytocin. So showing convenient regime. Okay, calculation of dose delivered in milliunit, correlation with drop rate per minute. So come to the 4 augmentation of labor. Augmentation of oxytocin infusion is used during labor in uterine inertia for augmentation of labor or in the active management of labor. The procedure consists of low rupture of the membrane followed by oxytocin infusion. When the liquor is clear, fetal-pelvic disproportion must be ruled out beforehand. Observation during oxytocin infusion: rate of flow of infusion by counting the drop per minute or monitoring the pump. Uterine contraction: number of contractions per 10 minutes, duration of contraction and period of relaxation are noted. Fingertip palpation of tonus of the uterus in between contraction may be done where gadgets are not available. Peak intrauterine pressure of 50 to 60 mmHg with the resting tone 10 to 15 mmHg is optimum when intrauterine pressure monitoring is used. Fetal heart rate monitoring is done by auscultation at every 15-minute interval or by continuous EFM. Assessment of progress of labor: descent of head and rate of cervical dilation. Indication of stopping the infusion. Nature of uterine contraction: abnormal uterine contraction occurring frequently every 2 minutes or less or lasting for more than 60 seconds. Hyperstimulation of polysystole. Increased tonus in between contraction. Evidence of fetal distress. Appearance of untowardness. Maternal symptoms. Diagnostic use of oxytocin. Contraction stress test, oxytocin sensitivity test. Contraction stress test synonym is oxytocin challenge test. It is an invasive method to assess the fetal well-being during pregnancy. When there is alteration in fetal heart rate in response to uterine contraction, it suggests fetal hypoxia. Fetal hypoxia principle: the test is based on determination of the respiratory function of the fetal-placental unit during induced contraction. When the blood flow through the unit is curtailed, the objective is to detect the degree of fetal compromise so that a suitable time can be selected to terminate the pregnancy. Candidate for CST: contraction stress test, intrauterine growth restriction, post-maturity hypertensive disorders of pregnancy, diabetes, and contraindications are compromised fetus, previous history of cesarean section, complication like to produce preterm labor, APS, multiple pregnancies. Procedure: the oxytocin infusion is started in the same manner as mentioned earlier. The initial rate of infusion is 1 milli-international unit per minute, which is stepped up at interval of 20 minutes until the effective uterine contraction are established. Wide supra: the alteration of the fetal heart rate during contraction is recorded by electronic monitoring. Alternatively, clinical monitoring can effectively be performed using hand to palpate the hardening of the uterus during contraction and auscultation of fetal heart rate during contraction and for 1 minute thereafter. It takes at least 1 to 2 hours to perform the test. Importance: a negative test is associated with the good fetal outcome, where the positive contraction stress test is associated with the increased incidence of IUD, fetal distress in labor, and low AP-agar score, but there is 50% chance of false positive result, and as such as positive test cases are subjected to other method of evaluation by physical profile. Doppler study: for the well-being of fetus. Suspicious CST should have been repeated in test 24 hours. Interpretation of contraction stress test: positive persistent lead deceleration of fetal heart rate with 15% or more of uterine contraction. Negative: no late insignificant variable deceleration suspicious intermittent rate of variable deceleration, unsatisfactory less than 3 contractions per 10 minutes, or an unpredictable tracing, hyperstimulation, deceleration with contraction lasting more than 90 seconds or occurring more frequently than every 2 minutes. Ergot derivatives. Out of many ergot derivatives, two are used extensively as oxytocins. These are ergometrine, methergine. Ergometrine, ergonovine in USA, methyl ergonovine in USA. Okay, chemistry. Ergometrine is an alkaloid isolated by Dudley and Moyer in 1935 from ergot, a fungus Klebsiella purpura that develops commonly in cereals like rye, wheat, etc. The alkaloids are detoxified in the liver and estimated in the urine. Methergine is a semi-synthetic product derived from lysergic acid. Mode of action: ergometrine acts directly on the myometrium. It excites uterine contraction, which comes so frequently one after the other with increasing intensity that the uterus passes into a state of spasm without any relaxation in between. Effectiveness: keeping the physiological function in mind, it should not be used in the induction of labor. Induction of abortion or labor. On the contrary, it is highly effective in hemostasis to stop bleeding from the uterine sinuses. Either following delivery or abortion. Methergine is somewhat slower in producing uterine response, taking 96 seconds in contrast 55 seconds by ergometrine when administered intravenously. Look at the table 34.4. Composition of different ergot preparation: ergometrine, methergine, centometrine, ampules and their tablets. Mode of administration of ergometrine. Ergometrine and methergine can be used parenterally or orally. As it produces tetanic uterine contraction, the preparation should only be used either in the late second stage of labor or following delivery of the baby. Centometrine should always be administered intramuscularly. Always intramuscularly. Look at the table 34.5. Comparative study of onset and duration of action of different oxytocins, IVIM, oral. Okay, ergometrine, methergine, centometrine, syntocin, puerperal uterus. Duration of action, duration of hazards. Common side effects are nausea and vomiting. Because of its vasoconstrictive action, it may precipitate rise of blood pressure, myocardial infarction, stroke, bronchospasm. Prolonged use may lead to gangrene of the toes due to its vasoconstrictive effect. Prolonged use in puerperium may interfere with lactation by lowering prolactin level. Use of ergometrine, methergine. Indication, contraindications. Indication: prophylactic and therapeutic. Prophylactic: active management of third stage of labor as prophylaxis of excess bleeding following delivery. Therapeutic: to stop atonic uterine bleeding following delivery, abortion, or expulsion of hydatidiform mode. Contraindication: prophylactic suspected pleural pregnancy. If given accidentally with the delivery of the first baby, the second baby is compromised with the tetanic contraction of the uterus. Organic cardiac disease result in sudden squeezing of blood from the uterine circulation into systemic circulation, causing overloading of the right heart and failure. Severe preeclampsia, eclampsia, sudden rise of blood pressure or development of fits. Rh negative mother, more risk of fetal-maternal microtransfusion. Therapeutic: heart disease or severe hypertensive disorder. Because of its vasoconstrictive effect, it may cause transient hypertension or cardiac failure, especially when given intravenously. Oxytocin is a better substitute in such cases. Caution: ergometrine should not be Caution: ergometrine should not be used during pregnancy, first stage of labor, second stage of prior to crowning of the head, and in pre-delivery prior to crowning. Comments: as a homeostatic in uterine hemorrhage following expulsion of the fetus, respective duration of pregnancy, ergometrine or methergine is a drug of choice. On the contrary, oxytocin is predominantly used to initiate uterine contraction and to accelerate uterine contraction in labor. Comparative study of ergot derivative and oxytocin. Ergot derivative oxytocin. Mode of action: ergot derivative act directly on myometrium, producing tetanic contraction with complete loss of polarity. Oxytocin act on the physiological uterine contractile system. Law of polarity is maintained. Onset of action comparatively slower. Oxytocin faster in action. Duration long sustained, and oxytocin short lived. Clinical: to stop hemorrhage following delivery, abortion, or expulsion of hereditary mode. Prophylactic use in late second or third trimester stage after separation of placenta and to minimize blood loss. 4. Clinical use of oxytocin in induction of labor, augmentation of uterine contraction. Stop postpartum or post-abortal hemorrhage along with the ergometrine in isolation. Hazards: ergot hazards, nausea and vomiting, rising blood pressure, stroke, rarely gangrene of the top. Oxytocin, uterine hyperstimulation, antidiuretic effect, uterine rupture, anginal pain, or rarely hypotension. Prostaglandins are the derivative of prostanoic acid, from which they are derived their name. Derivative of prostanoic acid. They have property of acting local hormone. Prostaglandins were the first described and named by von Euler in 1935. Chemistry: prostaglandin are 20 carbon carboxylic acid with cyclopentane ring, which are formed from polyunsaturated fatty acids. Of the many varieties of prostaglandin, PGE to PGF2 are exclusively used in clinical practice. The subscript numeral after later indication of the degree of unsaturation inactivation is done in lung and liver. Source: prostaglandin are synthesized from one of the essential fatty acid, arachidonic acid. Synthesized from arachidonic acid, which is widely distributed throughout the body. In the female, these are identified in menstrual fluid, endometrium residue, and amniotic fluid, amniotic membrane. Female identified in female in menstrual fluid, endometrium residue, and amniotic membrane. Prostaglandins. Increased biosynthesis of prostaglandin of E and F series in the uterus is prerequisite for labor, both term and preterm. Prostaglandins are paracrine autocrine hormone as they act locally at their source of site of production. Their half-life in the peripheral circulation is about 1 to 2 minutes. Decidua is the main source of PGF2 alpha. Fetal membrane produces PGE2 and the myometrium mainly produces PGI2. In vivo, PGF2 alpha promote myometrial contractility. PGE2 induce labor, cervical effacement and dilatation. It shorten induction to delivery interval. PG prostaglandins promote myometrial contraction irrespective of the duration of gestation, where the oxytocin act predominantly on the uterus at term or in labor. This has helped the widespread use of prostaglandin to effect first trimester medical termination of pregnancy and also for induction of labor at term. The side effects of prostaglandin are less used when used vaginally. Local application of prostaglandin gel is the gold standard for cervical ripening. Use in obstetrics, induction of abortion, termination of molar pregnancy, induction of labor, cervical ripening prior to induction of abortion or labor, augmentation of labor, management of atonic postpartum hemorrhage, medical management of tubal ectopic pregnancy. Contraindication: hypersensitivity to the compound, uterine scar, active cardiac pulmonary, renal hepatic disease, hypotension, bronchial asthma. Mechanism of action: both PGE2 and PGF2 alpha have got an oxytocin effect on the pregnant uterus when used in appropriate dose. The probable mechanism of action is change in myometrial cell membrane permeability and or alteration of membrane-bound calcium. Prostaglandin also sensitizes the myometrium to oxytocin. PGE2 is at least 5 times more potent than PGF2 alpha. PGF2 alpha acts predominantly on the myometrium while PGE2 acts mainly on the cervix due to collagenolytic property. PGE2 causes dissolution collagen bundle and increase of mucosal water content of the cervix. Look at the table 34.7 prostaglandins in obstetrics. Advantages and disadvantages and their side effect. Advantages: powerful oxytocin effect irrespective of duration of gestation. Induction of labor in case with low pre-induction score. Anti-uterine fetal death. Used in induction of abortion with success. It has got no antidiuretic effect. PGE1 can be used for augmentation of labor. Disadvantages: it is costly. Nausea, vomiting, diarrhea, pyrexia, bronchospasm, tachycardia and chills are the side effects. Cervical laceration may occur when used as an abortifacient. Tachysystole of the uterus may occur during induction and may continue for variable period. Risk of uterine rupture in case with previous scar. Preparation: prostaglandin E2. Prostaglandin E2 is widely used because it is less toxic and more effective than PGF2 alpha. Widely used. Vaginal tablet containing 3 mg dinoprostone, prostin E2 in the posterior fornix followed by 3 mg after 6 to 8 hours, maximum 6 mg. Vaginal pessary with retrieval device releasing dinoprostone approximately 10 mg over 24 hours. It is removed when cervical ripening is adequate. Prostin E2 dinoprostone gel 500 microgram into cervical canal below the level of internal os, or 1 to 2 milligram in the posterior fornix. Parenteral PGE2 intravenous prostin E2 containing 1 mg per ml, PGF2 alpha prostin F2 alpha dinorprostrone tromethamine containing 5 mg per ml, methyl analog of PGF2 alpha carboprost containing 250 microgram per ml. PGE2 is effective for induction of labor causing cervical effacement and dilatation. It reduces the need of oxytocin use and cesarean delivery. PGE2 preparation are relatively expensive and require refrigeration, otherwise it becomes unstable at room temperature. Methyl ester of PGE1 misoprostol. It rapidly absorbs more effective than oxytocin. Dinorprostrone for induction of labor. Misoprostol PGE1 has been used for cervical ripening. Primarily, it has been used for peptic ulcer disease. Used for cervical ripening and peptic ulcer disease. Transvaginal misoprostol is used for induction of labor. Oral misoprostol can be used as it is convenient to the patient. It is given 25 to 50 microgram every 3 to 6 hours by oral or vaginal route. Low dose of oral prostaglandin E1 dissolving 200 microgram tablet in 200 ml tap water 2 to 25 microgram in solution is safe. It is to be repeated at interval of 2 hours. Buccal and sublingual misoprostol is also used for induction of vaginal delivery. Oxytocin when this preparation also available. Buccal or sublingual. Oxytocin when needed may be added after 4 hours. Misoprostol has been found to be effective as PGE2 for cervical ripening and induction of labor. To date, no evidence of teratogenic or carcinogenic effect has been observed. Advantage of PGE1 over PGE2. Misoprostol has cheap, stable at room temperature, long shelf life, easily administered, has less side effect. Induction delivery interval is short. Need of oxytocin augmentation is less. Failure of induction is less. Risk: incidence of tachysystole, fetal heart rate changes, meconium passage are high. Rupture of uterus, though rare, has also been observed. It should not be used for cases with previous cesarean because the risk of rupture is high. Misoprostol is not yet approved for use in pregnancy by FDA. Use of misoprostol for induction of abortion has been discussed in 203 and 204. Tachysystole, contraction less than 5 in 10-minute average over 30-minute window. It may occur in spontaneously or stimulated labor. Fetal heart rate changes may or may not be present. Remark about oxytocins. All the oxytocins have got their place in obstetrics. To arrest hemorrhage following delivery, abortion or ergot preparation is the life-saving drug in refractory cases of atonic PPS, PGF2 alpha, IM intramyometrial or PGE1 misoprostol 1000 microgram rectal is an effective choice. For induction of labor, either prostaglandin or oxytocin can be used with favorable pre-induction cervical score. There is very little to choose between oxytocin and prostaglandin, but when the score is unfavorable, as in IUD, intrauterine death, shorter period of gestation or in early primary gravida, prostaglandin have been got a distinct advantage over oxytocin. Misoprostol has a certain advantage over PGE2. Got a distinct advantage over oxytocin. Misoprostol has certain advantage over PGE2. Augmentation and acceleration of labor. Oxytocin still enjoy popularity, although prostaglandin are also equally effective. Co-induction of abortion prostaglandin has got distinct advantages over oxytocin. Oxytocin may supplement the effect of PG in the process. Antihypertensive drugs. Antihypertensive drugs are essential when the BP is 160 by 100 mmHg to protect mother from eclampsia, cerebral hemorrhage, cardiac failure, and placental abruption. Aimed to reduce BP less than 125 mmHg. Their benefit is mild moderate hypertension is not yet known. If there is any risk of target organ damage, antihypertensive argument to maintain BP less than 140 mmHg. First line therapy is the methyl-dopa or labetalol. Second line is nifedipine. ACE inhibitors are avoided in pregnancy. The following are the drugs with their pharmacological property and clinical use in prevention given in table. Commonly used drugs are ergometrine, sympatholytic, adrenergic receptor blocking agent, vasodilator, calcium channel blocker, ACE inhibitor. ACE inhibitors are contraindicated in pregnancies. Okay. Now sympatholytic, methyl-dopa, reserpine, adrenergic receptor blocking agent, labetalol, propranolol, vasodilator, hydralazine, nitroglycerin, sodium nitroprusside, calcium channel blocker, nifedipine, nicardipine, ACE inhibitor, captopril, lisinopril. Look at the table 34.8 antihypertensive drugs. One column is for drugs, another for mechanism of action, dose, side effect, contraindication, and precautions. For methyl-dopa drug of first choice, central and peripheral antiadrenergic action, effective and safe for both the mother and the fetus. Dose orally to 50 mg BID may give increase to 1 gram QID depending upon the response. IV infusion to 50 to 500 mg. Maternal postural hypotension, hemolytic anemia, sodium retention, excessive sedation, Coombs test may be positive. Fetal intestinal ileus. Contraindications and precautions: hepatic disorder, psychic patient, congestive cardiac failure, postpartum. Hydralazine act by peripheral vasodilation as it relaxes the arterial smooth muscle orally as it weak and should be combined with methyl-dopa or beta blocker. It increases the cardiac output and signal blood flow. Orally 100 mg per day in 4 divided to IV 5 to 10 mg every 20 minutes, maximum 20 mg. Maternal hypotension, tachycardia, arrhythmia, palpitation, lupus-like syndrome, fluid retention, fetal reasonably safe, neutral thrombocytopenia. Because of variable sodium retention, diuretics should be used to control arrhythmia. Propranolol may be administered IV. Labetalol, combined alpha and beta adrenergic blocking agent, orally 100 mg TID may be increased up to 2400 mg daily. IV infusion during hypertensive crisis, 20 to 40 mg IV every 10 to 15 minutes until desired effect, maximum to 2 to 0 mg. Tremor, headache, asthma, congestive cardiac failure, efficacy and safety with short-term use appear equal to methyl-dopa. Contraindication: hepatic disorder, asthma, congestive cardiac failure. Nifedipine, direct arteriolar vasodilation by inhibition of slow inward calcium channels in vascular smooth muscles. Orally 5 to 10 mg TID, maximum dose 60 to 120 mg per day. Flushing, hypotension, headache, tachycardia, inhibition of liver. Contraindication: simultaneous use of magnesium sulfate could be hazardous due to synergistic effect. Sodium nitroprusside direct vasodilator. IV infusion to 0.25 to 8 microgram per kg per minute. Maternal nausea, vomiting, severe hypotension. Fetal high toxicity due to metabolite cyanide and thiocyanate. Drug of last resort for acute hypertension should be used in critical care unit for very short time. Nitroglycerin relax mainly the venous but also arterial small muscle. Given as IV infusion 5 microgram per minute to be increased at every 3 to 5 minutes up to 100 microgram per minute. Tachycardia, headache, hyperglycemia used in hypertensive crisis for short term only. Contraindicated in hypertensive encephalopathy as it increases blood flow and intracranial pressure. ACE inhibitor inhibit formation of angiotensin second from angiotensin 1. ARB block angiotensin second receptor. Captopril orally 6.25 mg. Telmisartan orally 20 to 40 mg per day. Maternal hypertension, headache, arrhythmia. Fetal and oligohydramnios, IUGR. Intrauterine growth retardation, fetal renal tubular dysgenesis, neonatal renal failure, pulmonary hypoplasia should be avoided in pregnancy. Suitable for chronic hypertension in non-pregnant state or postpartum. Diuretics. The diuretics are used in following conditions during pregnancy: pregnancy-induced hypertension with pathological edema, severe anemia, and pregnancy with heart failure. As an adjunct to certain antihypertensive drugs such as hydroxyzine and digoxide. Eclampsia with pulmonary edema prior to blood transfusion, severe anemia. Common preparation used are furosemide, thiazide, and spironolactone. Furosemide loop diuretic, dose 40 mg tablet following breakfast 4-5 days a week. In acute conditions, the drug is administered parenterally in a dose of 40 to 120 mg daily. Mode of action is directly prevent resorption of sodium and potassium mainly from the loop of Henle. Hazards maternal include weakness, fatigue, muscle cramp, hypokalemia, postural hypotension. These can be corrected by potassium supplement during therapy. Fetal and preeclampsia, it is routine use should be restricted as it likely to cause further reduction of maternal plasma volume which is already lowered. This may result in diminished placental perfusion leading to fetal compromise. Other hazards include thrombocytopenia, hyponatremia. Thiazide diuretic is often used in conjunction with other antihypertensive. It is safe in pregnancy. Dose 12.5 mg twice daily, maximum of 250 mg daily may be used. Side effects are maternal fetal hyponatremia, acute pancreatitis, rise in uric acid level, and neonatal thrombocytopenia. In a diabetic patient, it may cause hyperglycemia. Spironolactone potentiates thiazide and loop diuretic by antagonizing aldosterone. At a potassium-sparing diuretics contraindicated in hyperkalemia. Drospirenone is analog of spironolactone. It has anti-androgenic and anti-mineralocorticoid properties. The dose of used in cirrhosis is usually not associated with hyperkalemia. Tocolytics agent, anticonvulsant. Tocolytic agent. Preterm labor and delivery can be delayed by drug in order to improve the perinatal outcome. Short-term delay of 48 hours allow the use of corticosteroids that can reduce the perinatal mortality and serious morbidity significantly. The commonly used drugs are beta-mimetics, prostaglandin synthetase inhibitor, magnesium sulfate, calcium channel blocker, oxytocin receptor antagonist, nitric oxide donor, progesterone. The commonly used drugs are given in table 34.9. Calcium channel blocker, nifedipine, nicardipine, verapamil. Nifedipine blocks the entry of calcium inside the cell. It is equally effective to MgSO4. Magnesium sulfate, dose oral, not sublingual, 10 to 20 mg every 3 to 6 hours. Side effect and precaution: mental hypotension, headache, flushing, nausea. Combined therapy of beta mimetics or MGSO4 should be avoided. Magnesium sulfate, it active as a competitive inhibitor of calcium ion either at the motor and plate at the cell membrane, reducing calcium influx, decrease acetylcholine cooling release, and sensitivity at motor and plate direct depressant action on the uterine muscle. Loading dose 4 to 6 gram IV, 10-20% solution over 20 to 30 minutes, followed by infusion of 1 to 2 gram per hour to continue tocolysis for 12 hours after the contraception. Have stopped tocolytics effect is poor. Magnesium sulfate relatively observed. Common maternal side effects are flushing, perspiration, headache, muscle weakness, rarely pulmonary edema. Eventual side effects are lethargy, hypotonia, rarely respiratory depression. Monitoring needed. Okay, contraindication: myasthenia gravis and impaired renal function. Endomethacin clock, seasonase inhibitor, sulindac, another NSAID, is also used. It has a less placental transfer. Reduce synthesis of prostaglandin, thereby reduce intracellular free calcium activation of MLCK and uterine contraction. Prostaglandin causes increase in free intracellular calcium and activation of MLCK. Loading dose 15 mg per oral or per respiration per rectal, followed by 25 mg every 6 hours for 48 hours. Maternal heartburn, asthma, GI bleeding, thrombocytopenia, renal injury, patellar dysfunction, contraindication, hepatic disease, active peptic ulcer, coagulation disorder, fetal and neonatal side effect: constriction of the ductus arteriosus, oligohydramnios, neonatal pulmonary hypertension, IUGR. Beta mimetic, terbutaline, litotrin, azoxystrobin, mechanism action: activation of the intracellular enzyme adenylyl cyclase (AMP) supporting kinase, reduce intracellular free calcium and inhibit activation of MLCK, reduce interaction of actin myosin, smooth muscle relaxation. Beta 2 receptor stimulation causes smooth muscle relaxation. Dose: litotrin is given by IV infusion 50 microgram per minute and is increased by 50 microgram every 10 minutes until contraction ceases. Infusion is continued for about 12 hours after the contraction ceases. Terbutaline has a longer half-life and fewer side effects. Subcutaneous injection of 0.25 mg every 3 hours to 4 hours is given. Side effect and precaution: side effect of beta mimetic are more when used parenterally. Maternal headache, palpitation, tachycardia, pulmonary edema, hypotension, cardiac failure, hyperglycemia, ARD, hyperinsulinemia, lactic acidemia, hypocalcemia, even death. Fetal tachycardia, heart failure, IFT, neonatal hypoglycemia, intraventricular hemorrhage. Oxytocin antagonist, atosiban. Oxytocin analog antagonists that block mimetic oxytocin receptor. It inhibits intracellular calcium release of prostaglandins and thereby inhibit myometrial contraction. IV infusion 300 microgram per minute. Initial bolus may be needed. Nausea, vomiting, chest pain are the side effects. Nitric oxide, glyceryl nitrate, smooth muscle relaxant, patches, doses as a patches, and side effects and precautions may cause cervical wrapping, headache. Anticonvulsant. Convulsion in pregnancy is largely due to eclampsia. Other causes are epilepsy, meningitis, cerebral malaria, cerebral tumor. Eclampsia should be considered first use unless approved otherwise by history examination and investigation. The commonly used drugs are given in tabulated form: magnesium sulfate, diazepam, and phenytoin. These three drugs are prescribed. Magnesium sulfate, it decreases the acetylcholine release from the nerve ending and reduces the motor and plate sensitivity to acetylcholine. It also blocks the calcium channels. It causes vasodilation, increases cerebral, uterine, and renal blood flow. It decreases intracranial edema. Dose: intramuscular. Loading dose 4 gram IV 20% solution over 3 to 4 minutes to follow the 10 gram deep IM 5 gram in each bottle. Maintenance dose 5 gram deep IM on alternate bottle every 4 hours. IV loading dose 4 to 6 gram IV over 15 to 20 minutes. Maintenance dose 1 to 2 gram per hour IV infusion. Repeat injection are given only if knee jerk are present. Urine output more than 30 ml per hour and per respiration rate more than 12 per minute. Therapeutic level of serum magnesium is 4 to 7 milliequivalent per liter. Magnesium sulfate is relatively safe and is the drug of choice. Muscular paresis. Diminished knee jerk, respiratory failure, renal function is to be monitored. It does not affect the duration of labor. Antidote injection calcium gluconate 10% 10 ml IV. Fetal effects are usually absent. It is contraindicated in patients with myasthenia gravis. Diazepam, central muscle relaxant and anticonvulsant. Initial 20 to 40 mg IV to be followed by an infusion containing 500 ml of dextrose with 40 mg of diazepam. The drip rate being 30 drops per minute or adjusted as per need. Status epilepticus 10 to 20 mg IV slowly to be repeated if needed after 1 hour may be followed by IV infusion to a maximum of 3 mg per kg over 24 hours. Side effect mother hypertension, fetal respiratory depressant effect which may last for even 3 weeks after delivery. Hypotension, thermoregulatory problem in newborn. Phenytoin, centrally acting convulsants. Eclampsia 10 mg per kg IV at the rate of not more than 50 mg per minute followed 2 hours later by 5 mg per kg. Epilepsy 300 to 400 mg daily per orally as in divided dose. Status epilepticus 80 mg per kg slow IV 50 mg per minute. Maintenance dose of about 100 mg is given at an interval of 6 to 8 hours. BP and ECG monitoring should be done. Maternal hypertension, cardiac arrhythmia, phlebitis as the injection site, fetal hydantoin syndrome. So it is contraindicated during pregnancy. Is observed in 5 to 10% outsiders. This may be due to the disease itself with a genetic predisposition or due to drug metabolism deficient folate level. Anticoagulant. Anticoagulants are not commonly used in pregnancy. Cardiac disease, venous thrombosis, antiphospholipid syndrome are some of the indications. Indications for use of anticoagulant are cardiac disease, venous thrombosis, antiphospholipid syndrome. The commonly used drugs are discussed here. Table 34.11 anticoagulant drugs are heparin and warfarin. Heparin contraction, heparin low molecular weight heparin. Mode of action, dose and side effect. Mode of action, inhibit action of thrombin. It also enhances the activity of antithrombin. Third, increase factor 10A inhibitor. Antidote, potassium sulfate. Dose 5,000, 10,000 international unit to be administered parenterally. DVT and pulmonary embolism loading dose 5,000 unit IV followed by continuous infusion of 18 unit per kg per hour. Pregnancy 5,000 to 10,000 subcutaneous every 12 hours with monitoring. Low molecular weight heparin, enoxaparin 1 mg per kg twice daily. Subcutaneous less antithrombotic effect. Maternal hemorrhage, urticaria with long-term thrombocytopenia and osteopenia, hyperkalemia. Fetal, it does not cross the placenta, not teratogenic. Low molecular weight heparins as effective and safe as unfractionated heparin. Longer half-life and once daily dose is convenient. Standard dose not require monitoring. Warfarin interfere with the synthesis of vitamin K dependent factor. Second 7, 9, 10. 5, 10 mg orally daily for initial 2 days, then 3 to 9 mg daily taken at the same time for each day depending upon the prothrombin INR. Okay, maternal hemorrhage fetal warfarin, embryopathy, nasal hypoplasia, bone stiffening, optic atrophy, mental retardation, microcephalic chondrodysplasia punctata, women with mechanical heart valve. Warfarin is preferred to avoid in first trimester. So now I'm signing out from part first of this video.